There are 7 genotypes that are circulating worldwide. But what is important is that actually if you look at Europe or the US, for example, you have genotype 1, which is roughly 50% of the patients infected with chronic hepatitis C. Genotype 2 and 3 and 4 make up the other 50%. While genotype 5, 6, and 7 are very, very rare in Europe, for example, they are more common in South Africa or the Far East, which means China, Korea, and Indonesia. The problem has always been that the drugs we had were poorly effective and poorly safe, so the patients had tremendous side effects. And in terms of efficacy, the efficacy rates were near 50%, which is not what we were shooting for. So in theory, hepatitis C was a curable disease, but the efficacy rates of the drugs we had in the past were really dismal. At ILC this year, we have the final results of the phase 3 studies of the ABBV-3D combination, which is an incredibly safe regimen, just all oral, no interferon. It was studied in genotype 1 patients in the SAPPHIRE-1 and the PEARL-3 study, looking at the 12-week treatment regimen, so very short treatment, and the efficacy rates, the cure rates, were in the 99–95% rate. And the message you get from the PEARL-3 study is that if you have genotype 1B naive patients, which is a huge group of patients in Southern Europe, for example, you have around 99% SVR rates, which is viral cure, without ribavirin. So the pill burden is even lower, no side effects. Less than 1–2% of the patients had to discontinue for side effects. And this is incredible because in the past we had around 15–20% dropout rates during treatment for side effects. So this is a huge improvement for our patients. So this regimen is really close to being perfect. It has high efficacy rates, even in the most difficult to cure patients, and it has very, very positive tolerability profile, which means most of the patients will be able to start treatment and finish treatment and get a virological cure, which is great. We have 2 big aims for the future. The first one is to get these drugs in the very sick patients. So the patients with decompensated disease, the patients with kidney disease, and we have to see how the drugs do there, if they are efficacious and safe, as we hope, also in this very difficult to cure group of patients. And the second one, which is the main battle we will have to do in the future, is to get all patients to have access to treatment. So we have to negotiate with the drug companies, lower the price, have broad access to treatment in all HCV patients in Europe, in Asia, in Africa, in the US, because in theory, we could be able to eliminate the virus worldwide.